Hi everyone. Good morning, good afternoon, good evening, wherever you are in the global site. Today we have a panel discussion, a webinar based on the interesting topic in IVF. This is being organized by Life in Vitro Academy and Medinit, an educational platform. And we are going to discuss about as I said, the interesting aspect of IVF, that is the troubleshooting, a complex area in IVF scenario. As you know that IVF, it started from a simple process maybe 40 years back, and now it is gone into a complex scenario with the various process and quality management systems and different persons involved in IVF programs. So there is a lot of things involved in IVF laboratory. So today's panel discussion, we put it as finding a needle in a haystack, troubleshooting in IVF laboratory. Now I am handing over to our moderator, Dr. Gaurav Majumdar. He is a laboratory director at the Center for IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi, India. He is also the joint treasurer of Academy of Clinical Embryologists India and the executive committee member of Indian Fertility Society. Over to Dr. Majumdar.
Thank you, Alex. I'd like to now introduce all our experts and learned panelists who are going to discuss for the next 90 minutes about troubleshooting in the IVF lab. So I'd like to first welcome Dr. Laura Rinzi. She has academic degrees in biology and reproductive medicine and 20 years experience in embryology. She has authored more than 100 articles, reviews, and book chapters involved in educational, editorial, and practitioner activities. She is Genera Center's laboratory director and adjunct professor of biotechnology at the University of Urbino, Italy. Welcome, Laura.
Thank you. Welcome to everybody.
Next, I'd like to welcome Dr. Lars Johansson. He has over 30 years of experience in human-assisted reproductive technology, working as a clinical embryologist, lab director, and director of embryology at Cooper Surgical. His current position involves as an ART auditor and an ART consultant at New Life Aid Global, and he's an international scientific advisor to Life Air. Welcome, Lars. Next, I have Dr. Ronnie Jansen with us. He was a senior embryologist and quality manager of the Center of Reproductive Medicine of the University of Brussels, where he was responsible for implementation of a quality and ISO 17025 and later ISO 15189. And he audited for the Belgian accreditation body BELAC. He was with the team of Professor Van Struyten and Professor Paul Destroy as an embryologist in 1983. He worked with Gian Piero Palermo when ICSI was discovered at Brussels in 1992. Over the last years, he consulted in lab design, startup, troubleshooting, and functioning of several embryology laboratories worldwide, and is owner of BR IVF, a consulting company. Welcome, Ronnie.
Hi, thank you for the invitation and hi to everybody.
It's a pleasure to have you here. Next on the list of esteemed panelists, I have Dr. George Liperis. He's an ESHRI certified clinical and research embryologist practicing clinical embryology, combining genetic analysis and research in human reproduction. His current position is that of Deputy Scientific Director and Laboratory Supervisor at Westmead Fertility Centre, University of Sydney. Hi, George, and welcome to the discussion.
Thank you, Gaurav, for the introduction, and welcome everyone.
And finally, last but not the least, Dr. Alex Verghese. He's presently the scientific director at the Astra Fertility Group of IVF Centers in Ontario, Canada, and also holds the position of scientific director at Kraft Hospitals and Research Center at Kerala in India. And he was our past president of the Academy of Clinical Embryologists, India. So welcome, Alex. And let's now start the discussion. So most of the people here, we will be discussing for the next 90 minutes the topic of troubleshooting in the IVF laboratory, basically looking for a needle in a haystack. So I'll start by quickly sharing my screen. All right. So there we are. So just some quick basic understandings about what we mean by troubleshooting and what we want to address during the course of the next 90 minutes. So we will be talking about troubleshooting because when something goes wrong in the laboratory, it actually affects every single patient in the entire batch. So most of the situations that we will discuss are not anecdotal incidents, but they require troubleshooting at a larger level. Also, what is important to understand is that in most instances, troubleshooting may not work for all affected patients since there are no second chances and small errors can prove to be very costly. So this is something we need to keep in mind. Also, we know that in the IVF laboratory, if we think of troubleshooting as a cure, the first important thing is prevention, which is actually more important than troubleshooting, especially when, once the horse has bolted, there is no cure. And there are a lot of people who think that they have very, very good quality control systems in the laboratory and nothing can ever go wrong in the laboratory. But as Murphy's law states, if anything can go wrong, it will. And hence, let's start discussing situations in the IVF laboratory. So I'd like to begin by asking all panelists, all our experts, about describing one situation that they came across or heard in real life laboratory troubleshooting in their careers. So I would begin with Ronnie, perhaps, to start.
Okay. Thank you, Laura, for this introduction. Well, I'm not going to mention one specific point, but rather a general problem when doing troubleshooting, that is poor data management. If we as consultants or auditors or troubleshooters come to a place and you start examining, well, you need first to be able to define whether there is a problem or not, and that you do based on proper data. You can only identify a problem when the objective evidence, the data are available. So if the lab has poor data management or the data registration is incomplete or not correct, then troubleshooting is really impossible, and then we are really faced with searching a needle in a haystack. So it's not a specific thing, but it's unfortunately a finding which I encounter quite frequently visiting other places.
Thank you. Thank you, Ronnie. And now it's very interesting that when I asked this question to Laura, she had probably something similar to say. Please, Laura.
Yes, I fully agree with Ronnie. I mean, IVF is very difficult to control because we have many confounding factors. So if we don't have proper data management, we don't have a database, we don't keep all the KPIs under control, and KPIs are not only outcome KPIs, but it's the final problem. But first, we have to take under consideration the structure, the staff, the equipment, the consumables, and then, of course, the timings. Everything has to be under control. And even if we have everything under control and all the KPIs, we can have fluctuation in the IVF, which may not be because there is a problem, but because we are casually dealing with a different patient population. So it's not only laboratory outcomes that has to be kept under control, but also clinical data to be able to see if there is a confounder, maybe higher maternal age patient population. So you are dealing with worse patients, with lower results, and maybe what you're observing is only a standard fluctuation of patient population. I have a small example to report, which has been reported by an English colleague. I was thinking that my laboratory was really under control, but all the KPIs were there, but we were taking under control any variable possible. But then I discovered from her experience that nobody is checking the oxygen concentration in the incubator. I mean, the incubator alarms are related to the CO2 concentration, the standard free gas incubator. So in that case, she had a problem with a low oxygen tension because there was too much nitrogen inside the incubator because of a problem of the incubator itself. And so when she arrived in the morning, she had complete hypoxia in the incubator and no alarm was ringing because that kind of incubator didn't have a specific alarm for oxygen. And so we have really controlled every incubator to be sure that they have also not only the CO2 oxygen control, but also the CO2 control, but also the oxygen specific alarm.
Wow. Okay. So that is very interesting. Who could have thought that in addition to CO2, one also had to obsess about oxygen concentrations?
If you have oxygen, if you have a free gas incubator, in that case, it was not that there was too much oxygen, which is not so toxic for the embryo. So if the oxygen, if the nitrogen, if the oxygen comes to air concentration is bad, but it's not so bad. It's not really killing the embryo. But if you go to complete hypoxia, then of course the effect is dramatic with all embryos completely degenerated.
Okay. That's very interesting. Now, George, Lars, you had some anecdotes to tell us about your experience. Lars, do we have you here?
Yeah, trying to unmute me. No, well, when I go out and do the audits, like I do a lot, I usually stay for 5 days and I check everything. But I have some small comments, and it's actually like the previous speakers. At the same time, I think it's easier to find that something is wrong when it's really wrong. But if you have a drift in the results, then it's might be small multifactorial things, and they are much harder to get rid of. And it's all in the details. The devil's in the details. In one area of the world, I found that it was a lot of 3PNs, and they took out the eggs and injected them immediately afterwards. And I found that if I told them to delay it so you have a mature meiotic spindle, then they went from these 15 to 20% 3PNs to normal levels. And it was actually a way of getting the embryos back immediately. Sometimes they didn't even check if they had a fertilization. Yeah, low fertilization and poor embryo development after ICSI, that is also quite normal actually. And it's that when they make the dishes, when it's small volumes, they have very, very cluttered laugh benches, whether it's a class 2 or a normal laugh. And you actually get both that if you do too many dishes, but at the same time clutter the laugh bench, it doesn't work. It actually pulls in a lot of dirt. And then the type of pipettes, slim ICSI pipettes, lesser oversides and better temperature control. Some they say they do as they've been taught. And if you've been working in one clinic all the time, you learn maybe not the best way. So if you go around like most of us are doing, you learn so much more and what you shouldn't do actually. And it's a learning experience. And there's a lot more, of course, but the most common one is actually the environment and that they don't control the KPIs and that everyone is doing the same when they do the techniques. That's very, very common.
Thank you, Lars. And it's so interesting to see that simple fertilization and embryo development after ICSI could have been solved by just decluttering the LAF. These are very small things, tiny details that one tends to overlook. So thank you for that insight. George, if you could, do you have any anecdote to tell us about any troubleshooting incident?
Yes, both Ronnie and Laura talked about the KPIs. So I'm just going to give an anecdote about using one of those KPIs and seeing that the fertilization drops in the ICSI rates, in normal fertilization rates. So in order to solve that problem, we initiate the troubleshooting, and it's first important to identify.
George, I'm going to ask you that. I want to ask you to tell me about fertilization rates. I will pose that question to you in a couple of slides. So we will hold you for now.
Okay. All right. No problem.
Right. Couple of questions, and then I will ask you that same question. Alex, you have anything, or should we move on?
Yeah, I agree with the panelists on these things. So we have to stick to the KPI and the total quality management or the data management system. I can just mention an example that I came across an Indian scenario, because you know that the gases that we use for the tri-gas incubators is sometimes a culprit for the outcomes. Since you mentioned about the prevention is better than the cure, I came across because we were doing a validation of a tri-gas incubator. So what we did in that clinic, we connected with the locally available carbon dioxide and nitrogen, and we did a sperm survival study along with a control in a small laboratory, small incubator that is connected to only carbon dioxide. So interestingly, next day after 24 hours, we found only 30 or 40% survival in the test. That means in the tri-gas test incubator, but in the other it was the same, around 70 to 80%. So we were thinking, what is the reason? We tried out all the options, temperature, everything was fine. Then we changed the CO2 connection to, because all the incubators were connected via Coda inline filter, they activated carbon. So that side was, there was nothing to do with that. So we changed to a medical grade, so-called medical grade gas in that tri-gas. Again, we tried the same, lot of experiment, but again, we found the same thing. In the Labotech small incubator with the same, all the locally available CO2, the sponsor was okay. So then finally, what we did, we tried to get us good quality gas, both gases from our vendor, and then it came back to the normal. So what I want to say is that sometimes the quality of the gas, not only the CO2, the nitrogen, which takes up the whole volume of the incubator, I think that is very important as part of when you are doing the validation study.
Quality of gas is very, very important. All right. So now we move on to the next question. So there are so many crucial parameters that one has to worry while troubleshooting, and there are many situations when people are at a loss about what to address first, or probably try a quick fix solution when faced with a problem. So there's temperature, and you have to worry about the CO2 or the culture media or the air quality, for God's sake, wondering if there's something going wrong with the air quality, or oil or gas or plasticware. So now I would like to ask every single panelist here about the one component in the IVF lab that they think is perhaps the most variable and hence becomes the most crucial as well when troubleshooting, and probably the first go-to parameter for them while troubleshooting. So, Alex, what is that one thing for you?
I will go with the recent.
You mute yourself for a moment. And let's see, Ronnie.
Yeah, until Alex comes out of his aquarium, I hear some very nice water-like sounds. Again, I'm not going to pinpoint one specific item, but for me, the question was which component is the most crucial for me. It is, or it are the embryologists. Unfortunately, there are quite some rather small laboratories, and in those places, people tend to have to work independently or without proper supervision or training. And there, it is not uncommon that people commit errors against the physical issues which you listed in your previous. And to me, it's a sign of inexperience or lack of experience or just the wrong mindset. I think a good embryologist has a bit, or should be at least autistic, so that he should be able to repeat the same things in the same way over and over and over again.
All right.
The most variable, the weakest link is for me the embryologist. So we should try to search or look whether they are well trained, doing the right things, and not making the same mistakes against temperature, osmolarity, pH, whatever, all these issues.
And think of it that we did not even mention the operator or the embryologist in the previous list. What about you, George? In one word.
In one word, that would be temperature. The reason is because temperature is associated with so many different processes within the IVF laboratory.
Okay.
So we have the handling stages where we handle our gametes and embryos at the laminar flow hood, at the X-rig, at the tube warmers. We have the incubator itself, where again the temperature is variable between shelf to shelf. We have the cultured media as well, and its stability during transportation and during storage. Same for the plastic, where if they're not in a room where the temperature is stable, it can lead to buildup of plasticides. We also have environmental seasonal changes, and I know now we don't have 4 seasons, it might be just the 2 seasons, but still within the 2 season frame there is a bit of a variance, and that can lead to different cooling and warming rates. So we need to adjust and temperature map everything that we have in the laboratory in terms of keeping the temperature again stable. And when we say stable temperature, it means not just the display, it's not just what we see on the heated stage or at the warming stage, is what is actually being within the drop at the exact same conditions, the exact same media, the exact same dishes that we're using. But also the room temperature is very important, because if a room overheats, that can lead to overheating of the incubators. You don't want to come in the morning and find that your incubator has broke down and all your cultures are gone because of the air conditioning going off.
So in a nutshell, then temperature is very, very...
Temperature, for sure.
Laura, what according to you is very, very important for you?
I think that it's a little bit a mixture of all the previous answers, because if you are a very good embryologist, but you don't have a technology in your lab, you don't have good incubators, good warming plate, good air conditioning, good environment control, you cannot have good results. And on the opposite, you have very good instrumentation and you don't have a good operator that is able really to control everything, it cannot work. So I think that operator or embryology is better than operator. Is, I think, less nice for embryologists, but has to have a mind set for every single step of a treatment, but also I was saying culture dish preparation, the culture system where the embryo are exposed, including incubators, because this is really the treatment that we are doing, a culture for 3 to 6 days of embryos that will be exposed to this environment for so long, and this will really may affect the quality. So it's a little bit of mixture of everything was said before.
Sure. Lars.
Yes, now I'm here again. Well, there's multifactorial everything, but if you have a Rolls Royce and you don't have any wheels, then it's a little bit hard to go forward. And I feel there are so many things that need to be right, but the that affects everything is actually the environment. But I also think that when you do culture dishes, for instance, like George was talking about temperature, then if you have the wrong, even if it's embryo tested plastics, they can release a lot of VOCs. And those VOCs, they are taken up in oil and also the media. And it's actually been shown that they are enriching in the culture medium. So if you do long-term cultures, you need to see that you have, it doesn't matter if you have an embryoscope if you don't do the drops in a proper way or you handling. There's also the media where you aliquot media.
All right.
And
I asked only one. Okay, great.
Oh, okay.
Yes. So
One.
It's
And
interesting.
you've written 3.
So it's interesting to see that we have the incubator here, and the most fascinating thing is that 3 people think that it's actually the embryologist, which is the biggest variable parameter in the lab, and then we have the temperature also. So all very fascinating insights. Let's now move on. Let's move on to the next question for Ronnie about. So we want to ask you if poor air quality, does it really manifest itself in IVF outcomes? And what are the exact outcomes of KPIs which do get affected because of poor air? Yeah, we'd like to comment on that.
Okay, this is a difficult issue. As Lars said, VOCs, the answer is probably yes, they are infecting IVF results, but the available evidence is not really, there are no randomized trials for obvious reasons. In humans, we cannot expose parts of our embryos to VOCs and others not. So the available evidence is more or less anecdotal or based on animal studies. Now, I would like to refer the audience to the Cairo Consensus on IVF Laboratory Environment and Air Quality. It's published in RBM Online. There is a list of publications there, and there is no single publication indicating the inverse, that it would not affect IVF outcomes. Now, which KPIs are affected? Again, that's a very, very difficult question. VOCs is a very heterogeneous group of products. Most frequent is alcohol, used for decontamination or disinfection. Aldehydes, that certainly is documented to be detrimental, but there are many, many, many others, and all of them can have another impact on certain KPIs. So there is no single answer to that. But it certainly does help to filter the air. There are reports from centers where the air handling systems has been renovated, and there are clear differences before and after installing a proper air handling unit. Now, the current standard for the current best practice is having an IVF laboratory in an enclosed box in overpressure, totally isolated from the outside world, let's say, because the most probable source of VOCs is coming from outside air, contaminated outside air, where one of the big sources is our procedure rooms, which is usually next to the laboratory, and anesthetic gases, for instance, are a known source. So all this evidence or all this literature indicates that there is an impact of VOCs. They can have variable influence on KPIs, and filtering air does help. The best systems are a combination of active carbon and chemical oxidation with potassium permanganate, or even photooxidation is used, but air filtration does help.
Okay, thank you so much. And I'd like to invite Lars to also give a comment, because he's been involved quite a lot with air systems.
Yeah, I mean, during my trips all over the world, I've seen the consequences of pollution, of course, and wrong air filtration systems. The most common things you see is actually that the cleavage rate go down and the blast conversion is much lower. Clinical pregnancy rate and increase in miscarriage. So there are publications in ASRM. There are 2 studies there. And I have a lot of other data as well for it, that VOCs are, so as Ronnie said, there are so many different families and they have to be taken away in multifactorial way. And the charcoal, they are holding back the contaminations. And then if it get humidified or getting overloaded, it releases them again. And for the potassium permanganate, it's actually oxidizing the VOCs, but it doesn't take away all these VOCs. And there's also been shown recently, which I was supposed to talk about in Aspire, that the VOCs are actually taken up in oil and furthermore enrich in the culture media. So the environment is very, very important for having good results. And as Ronnie said also, the environment is not only the ventilation system, it's us, because the staff also release a lot of VOCs. And all the equipment you select, all the plastics you're using, it can all generate very high VOCs and negative effects on the culture system.
All right, thank you. So thank you for underlining the importance of the environment and the VOCs. And I think we understand now that carbon is a very, very important solution for taking care of VOCs. Let's now move on to the next question. So once the environment is now sorted out, now this is a question for George Liperus, and now we come to the business end, troubleshooting, where fertilization rates have dropped suddenly over a month below the competence value of the laboratory, which was minimum at 65%. And suddenly, after rather a 2-month period, calculating the fertilization rates, and they have gone down. And what do we do now? How do we initiate fixing this problem?
So first of all, we will use the KPIs to find the drop in that fertilization. So fertilization rate is one of the most useful, if not the most useful indicator, because it's situated upstream other markers such as developmental rate, embryo utilization, and pregnancy outcome. So therefore, it can identify problems earlier on. So when we see fertilization rate drop, it's firstly important to see, is that universal? Does it come from both IVF or ICSI, or is it specific to one of the two techniques? Because then the troubleshooting would differ as situations change for one or the other. So if this is for both, then we'll take it as a separate measure. So let's say, for example, that the IVF first is what we notice that has dropped. Then we have to first start the analysis by seeing the patient characteristics and see whether there is any changes, any confounders for age, sperm factors, ovarian reserve, and do that by proper statistical methods. So once we see that that is not the cause, then we would move to see whether that has to do anything with staff performance and competency levels. So, for example, for IVF, it's a very simplistic method, the sperm preparation. However, we have to look at whether we're counting properly, especially when it comes to concentration, the post-prep sample. It could be that we are undercounting the sample, and then we can identify that if the rate of polyspermy has risen. It's also a good example that we know that the staff are following the right instructions. Sorry, Gaurav?
Yeah, for ICSI, I think when you mention staff performance, then probably for ICSI it is more crucial, right?
So ICSI is also very important. I'll go with for both techniques. But for example, following the protocols, let's say I noticed once one embryologist loading more than the insemination volume, and when I asked why are you doing that, the preparation form says that is different, and the answer was just to make sure. So you understand that even when it comes to staff performance, it doesn't only is required for the ICSI process, it's also for the IVF. Of course, for the ICSI, you can compare the fertilization rate and see whether those differ between different operators and whether there is a problem in training or a need for retraining for a specific member of staff, but that is also need to be looked after. So when it comes to the sperm production for IVF, it's very important that we keep good records, because sometimes so you have the laboratory there, but in terms of first the production itself of the sperm is very important, because the time of production to the time of analysis is very crucial. So we need to see whether we keep records of that, and proper record keeping is very important to see whether there have been delays in the analysis that could lead to dehydration and change of temperatures. Of course, the laboratory conditions is very crucial to be looked at. We have the temperature of the heated stages, the incubator culture conditions, the temperature, the pH, the osmolarity, the air quality. All of those need to be looked at carefully using validated instruments that have specificity for picking up the defined ranges. It's also very important to check the gas, the composition of the mixture of the gas. So we need to use a standard gas before we take any measures, especially if we're using, for example, a mixed gas. We have to validate that those gas that comes with certificates of analysis from a reputable provider, because the quality of the gas can be very, very important. We can also take readings of the gas using a gas analyzer, a gas analyzing device. And it is very important, though, before we take a reading, to measure a standard gas before, in order to calibrate and make sure that it's functioning correctly. Also, for air quality, I know Ronnie and Lars spoke a lot about that in the previous question. So we have to be able to verify that, especially when it comes to ICSI, where we're exposing more the gametes, especially during the macromanipulation for longer periods to laboratory air, make sure that the filters are being routinely checked, and we avoid introduction of any cosmetics inside the laboratory, any paintings, any construction, anything happening around that can affect. Also, for the infection control, of course, using good hygiene, and if we suspect that there could be some infection, then we can use settle plates and culture those in order to see whether we have any bacteria or fungi.
Mm-hmm. So would you
Yeah.
in normal course, whenever there's a dip in KPI like fertilization rate, which is very vital, so you would follow this particular flow chart, like step by step. You would keep eliminating every option like this, and then moving on to the next thing.
The first thing would be to first define if that drop comes with IVF or ICSI, because different things are going to be looked at for the different processes. It affects different processes, the one from the other. For example, with the ICSI, the focus would be on mainly the stages of the manipulation, the laboratory air, and toxicity of the utensils. With the IVF, it might be the lots of the fertilization media. It might be anything to do with the preparation methods of the sample. So also the incubator humidity would be looked at, and of course tissue making and dish making is very important for both techniques.
Mm-hmm.
So toxicity of utensils, of course, that's very important. So any new lot introduced for plastic and media needs to be tested. And that needs to be tested either by using sperm survival methods, or if we have access to unfertilized oocytes or abnormally fertilized embryos, then, and if it's difficult to use, then we can use those to test our toxicity for the media and the plastics.
Right. So thank you, George. So what we understand is that you think that toxicity of the utensils, or in other words, the consumables, is very important. Laura, now if one has a competent rates in IVF, however, if the ICSI fertilization rates alone are showing a slow decline over a long period of time, this is not something which happens suddenly. So we're not undertaking a troubleshooting where something like this happens immediately, but over a period of time, through a year, slowly the ICSI rates are slowly declining, whereas the IVF fertilization rates are fine. They're doing great, because we've gotten such queries before. So how do you think this situation differs from what George is talking about?
Oh, so I don't think that they differ so much because the methodology would be the same. Once you get under the standard, although it was slow or rapid, I think you have to reevaluate the whole procedure. Mm-hmm. So it's funny because I made more or less the same flow chart that George did. First patient population, confounders. Yeah. Many times we think that we are facing a problem, but maybe it's just the population that is changing. And you have more ontological problems or more secretary endospermia, and you don't really realize when you put all the eggs together and you just look to the fertilization rate. So proper statistics is really essential. If you don't have a database and proper statistics to rely on the data, you may really think that something is going wrong and maybe it's not. But if you have a comparison, you have a control, which is standard IVF, and you have a problem, just fertilization rate to ICSI, then you have to check whatever is different between IVF and ICSI. So I would go to all the procedure that differs, procedure, manuality, consumables, media, drops, whatever has been done for ICSI that is not normally done for standard IVF. And this is in particular related to all the timing, the methodology, the media, the volume used for denudation, because this is a big exposure outside of the incubator. So, for instance, timing are very important. How long does it take to make a denudation? Maybe at the beginning you were denuded only 5 oocytes at the same time, and you could have a very nice fertilization rate with ICSI because everything was really under control one by one. And with time, you start to denude 20 oocytes together, so the denudation process will be longer. The ICSI process will be much longer. You will have a pressure over time. You will start to inject with less cautious, so more aggressively. So timing, consumables, procedures, operator of every single step that differs from your control will be the key where you find the problem, if a problem is not related to the patient population.
Laura, what do you have to say about the method of injection? Do you think we understand from what you said that too aggressive is not good. But do you think going too soft also maybe affects fertilization rates in the long run?
Look, I think that first of all, we have to understand why fertilization rate after ICSI has decreased. It is because the generation rate increased. Then I would think about too much aggressive ICSI. Is it because you have no activation at all? Then I would say maybe you are too soft and you're not activating or you're not breaking the membrane. So do you have 1 PN or 3 PNs? Is different. So fertilization is the 2 PN rate. But then we have to look to the non-2 PN rate fertilizer oocyte and try to understand which is the problem. And probably if it's a high degeneration rate, this I would assume that is related to the size of the pipette and the way you move the pipette inside the cytoplasm.
All right, great. Thank you so much. That is very, very interesting. That the kind of pipette as well as the aggression of injection can increase the degeneration rate. But at the same time, when you go too soft or too gentle, you fail to actually activate the oocyte. All right. So yeah. So this is just a slide telling us how important timing also is that Laura just talked about. So whether it is about cumulus removal or denudation, insemination or injection or sperm preparation, everywhere timing has been now re-emphasized that one of the most important parameters. So now let's now Alex, this is a question for you. How do we, like Laura just mentioned, so in a particular laboratory where they somehow managed to increase the damage rate post-ICSI to about 15%. So how do we curb the situation? How do we fix it?
So when it comes to the ICSI damage rate, there could be multiple reasons. So if you have a competent ICSI practitioners, then you can rule out that situation. And usually 3 kind of patterns you can see when you do the injection during the ICSI. That maybe when you pass the injection needle, there is a sudden kind of blossom coming out. That's the first thing. Second, there is kind of difficulty in injection, but you go in and there is a large funnel. That is another scenario. And the third is kind of a soft injection. You get a small kind of funnel. There won't be any issues. So sometimes the degeneration might happen during that denudation time. That may be due to the transpiration pressure changes, or maybe during the injection time, or maybe you are doing the injection or fertilization check. So another that might be interesting that I have come across my experience in some IVF center is that when I was directing lab, I have seen that many embryologists are scared to do the ICSI. The thing that even a competent embryologist were getting good number of degeneration in that clinic. So when we looked at that particular scenario, we have seen that they were giving high doses of more than maybe 350 to 400 units of recombinant FSH to most of the patients in the antagonist protocols. And they were not using any HMG, LH, recombinant LH, anything, nothing at all. So, because I have seen some other centers when in my earlier years when I was practicing, say, when they were using only HMG, even if you multiple times you inject those, nothing happens to that. And I suggested that director of the clinical program to give at least maybe in the that after this later after 5 days, 6 days to give the LH maybe recombinant. So when they started that, we have seen reduction in the degeneration rate. Otherwise, what we used to see, less PV space, and maybe only PV space that we used to see is only near to the polar body. And some embryologists in that program, they used to inject near to the polar body. They were telling that I want to survey myself in the clinic, not the oocyte. So that was the scenario sometimes. So I think it is not only maybe
one would never think that stimulation protocols could inherently affect oocyte quality. Do I have any other comment from any of the other panelists on this? Because this is.
I think there is no real evidence in the literature. There was very, very few papers, but not powered enough. So I think simply that you give more drugs to patients that have a lower ovarian response, and it may be related to the patient population. Sometimes we make the mistake between the therapy and the indication why this therapy is done. So potentially it's not because it was with a higher dose of FSH or whatever, it's just because it was the population of lower responders with potentially a lower number of eggs and worse quality.
Possibly.
Yeah. I would say the same as Laura. When you have bad or low fertilization rates, it usually depends on the background of the patient. And the worst scenario is actually to have poor responders, few eggs, and they're trying to get those small follicles also and getting more eggs, but they're not mature. And at the same time, you get sperm that are terrible. And the combination of the two is devastating for the outcome. It doesn't work. The other thing I just wanted to mention is that aggressive denudation, too quick denudation, aggressive denudation, you might have oocytes, but when you inject them, you have like a flat tire, and then when you push in the next, it goes lysing. And that is aggressive denudation, I feel. And also the wrong pipettes, when they are like more, they're not slim all the way. Then you also push in a lot of pressure inside the egg. And then the other thing that we did in 88 when we were doing the SUSI, we always inject at the polar body area because we released the live sperm swimming in, and it fused immediately if it was acrosome reacted. So we had acrosome reacted sperm, and we didn't have to inject the oocyte. And the other step now is piezo-ICSI, which is coming more and more, especially in Asia, where I've been a lot. And it definitely gives you better results and less killing of oocytes. And that is just an observation.
So it would be useful. So as I'm learning from the flow chart that was given by, was spoken to by George and Laura, I think the most useful thing would be to first compare the patient populations and make sure that they're not, that is not the main confounder, that is poor responders or aged patients. And then perhaps go on further with looking at denudation and ICSI with a magnifying glass. So
yeah, but you need a power. Sometimes if you're just looking to 20 patients, you will never get a statistical power. So it's very difficult to use the proper statistical methods when you have not so many cases to be analyzed. So it's tricky, it's difficult.
We noticed that you put that in bold, that this has to be done by statistical analysis and not impression based. Yes. Thank you. So, all right, now let's go to the tough one. The day 3 embryo quality has suddenly dipped in a laboratory, and the blastulation rate becomes half, literally half. So now, and this is probably after good fertilization, and we've already looked at the patient population. This is a high volume laboratory with hundreds of pickups being done per month. So now when such a thing happens, what is the first thing? What is the first thing that you will be skeptical about, that you will doubt to find a quick fix? Because this is crucial and it's affecting our overall KPIs. We know that we need to get a grip on the situation quickly. George,
with one word, fire the lab manager. No, that's just a joke. So you said about the high volume, but that the high volume graph is not the only thing to look at when it comes to the population of patients. We have to also look at particular characteristics. And I will give a particular example for us in Australia that we use the Medicare system, for example, and that creates low cost for a patient when it comes to the end of the year for repeated cycles. So then we have a lot of the patients that had a lot of poor cycles before, that we expect to have a less optimal outcome coming and piling up within the months of November, December. So everything has to be looked into context. It's not just the volume of the patients coming through, it's also particular situations. Similarly, for example, when we had the bushfires and it affected the air quality and a lot of our filtering systems maxed out and we had to replace them at a quick time. There was a lot of need for new filtering systems for all the laboratories in Australia, but not enough supply. So even sometimes when you try to be proactive, sometimes you can't control everything. But having in mind that we see that the day 3 embryo quality, we cannot attribute that to semen quality. It has to be something to do with the lab conditions. I would say that there is 4 pillars to be looked at. Is having a good laboratory condition with good critical equipment and equipment to monitor. Is to have a quality control system in place that we know how to use. Is to have good quality culture media and plasticware, and to have staff that knows how to use the equipment, that had proper training and can be assessed by the KBIs. So I would say that if any of those pillars, something goes wrong, then the whole structure collapses. So they are equally important. Of course, there are specifics when it comes to the quality to look at, like gas would probably be the main thing to look at first, but any of those 4 can contribute to the outcomes.
That's interesting that you mentioned gas. Lars, out of these 4 pillars that George has mentioned, what is perhaps the most important for you that you would go to at the first thing?
Well, I would look into, first of all, if they change anything with the stimulations also, because it's not only the lab that is doing this.
Probably not likely that they would have changed, because stimulations tend to go on in a similar fashion through and
Okay.
through. Yeah.
Then I would look into the temperature control, pH, but also the environment. I'm coming back to the environment a lot on this, because we know that delayed cleavage is also related to environmental problems, the VOCs again, but also sperm factors. They start affecting the embryo development later on in day 3, day 4.
What about culture media?
Culture media, definitely. If since I've been a lot in Asia, when you aliquoting a lot of media, you take it from the produced controlled environment in the dishes and put it in a test tube that is not embryo tested at all. So you take up a lot of toxins, and then you use that for making the mini droplets or anything you do. And that is a big problem, actually, because also you should be aware of the Monash cat, Sally, and oh my God, you're gonna kill me. Cat, anyway. Sally cat. They looked into the disposables and measured VOCs, and also embryo tested dishes and disposables were high in VOCs. So just because they're embryo tested doesn't mean they're non-toxic. So that's a learning curve for me when I saw this data. So it could be many things, but also age factors. You didn't say in much about the sperm, but sperm preparation and sperm handling and what you're doing with them can also affect your results. And high age partners, that also a big problem. You can see that in oocyte donation programs.
Those things will not tend to, suddenly change probably during a particular month. Anyone else has a comment to make about culture media and disposables?
I think one additional thing to look when it comes to culture media is exposure to temperature and sun rays and UVs. Some labs might have windows and they might think that it might be a good idea to get some sunshine, but that's not a very good thing for the creation of reactive oxygen species and dysregulation of calcium and the depletion of antioxidants in the culture medium. So also, like, careful attention when it comes to the media to look at expiry dates, whether there is any precipitation, whether the media is cloudy.
I'll interrupt you, Laura. What is your opinion on light and exposure to light in the laboratory?
Okay, there is different light sources. If it is the sunlight, I completely agree. We have to avoid completely to have any windows and any direct sunlight, of course, because it's bringing UV and a lot of other potential dangerous source of contamination for the embryos. But when thinking about the light inside the lab, which has been a matter, artificial light inside the lab, I think that artificial light inside the lab is really very important, and biologists has to be able to see what they're doing. And I think it's a little bit funny that I see a lot of laboratory with a closed light in the lab, but then the embryos are always exposed to light on the laminar flow or under the microscope. So what is the purpose to take out the light for embryologists' daily work and keep, when embryos are outside the incubator, the embryo under the light, under the microscope? So I believe that there is no real evidence that artificial light are toxic for the embryo. This is old studies related to some component of the culture media which were light sensitive, which are not anymore in our culture media. We can use a different light source with filters, but for me, the most important is to ensure that the embryologists can see very well what they are doing, read the labels, being able to write down the data and being comfortable in the lab to be sure that it can really make efficiently the job.
Thank you. So I basically asked you this because we have come across laboratories which are dark and they're constantly working in difficult, very, very feeble lights. And so it's great that you cleared that for us. Now,
just another input, Gaurav, sorry. Yeah. It's also for the media, it might be important to test the pH for every new lot that is being introduced in the laboratory prior to use.
Right. That will help reducing the variation to a great extent as far as culture media is concerned. Yes, that's very important. Check pH of every batch. Now let's move on from the laboratory, and I'd like to ask Ronnie to come in with a comment about what is the fundamental problem where such fluctuations tend to creep in the IVF laboratory. What on a fundamental level are we doing wrong?
Yeah, well, we heard many things to control in earlier contributions, but the point is, when you have a stable process in your laboratory, then there is no reason, if it's working today, why it should not work tomorrow. If there are fluctuations, this means that something has been changed. And well, this is one of the excellent literature on what to control. But when there are changes, it means your process is not in control. I am a control freak, and I think I'm really convinced that as laboratories, IVF services, we should more adapt good manufacturing practice principles, control everything to the maximum, and many of the variables which we heard are things which can be controlled if you do it properly. So we need to invest, in my opinion, in more quality control and good manufacturing practices. So when you start or when you establish a new process, you need to have the evidence how it's working and why it's working. You need the data, and you need to know the variables which you need to control and the limits these variables can vary. So good manufacturing practices, and this means controlling. To my opinion, and this might be a bit controversial, I think IVF is too cheap. We need to invest more in controls.
Very, very hard work, and that's why everyone should get a hold of this copy of this very important paper which was published last year, that there's only one thing that is truly important in an IVF lab, and which is breathing. Yes, Laura, please.
Yes, I fully agree with Ronnie. I know Ronnie is 25 years now, I don't know. So I learned from him really the quality control and everything. I was very lucky to go in Brussels at the beginning of the X series. So, but we have to keep in mind a second aspect is that not all the oocyte and or not all the sperms are equal. Mm-hmm. So patient population per se has a high fluctuation. Of course, if you are in a center where you do 200 cycles per month, this fluctuation will be much lower because you compensate with high numbers. But when you are dealing with 20 cases per month, it's normal, but the patient distribution will be different, and you may have fluctuation in the results. So the problem is really to be able to understand that we are not working with machines, but we are working with eggs and sperm that are highly different. And I would like to add only something, because you may have everything under control, but in the wrong way. For instance, when you calculate the fertilization rate or the testis development rate, patient is 1%, and not each oocyte is 1. Because, of course, the oocyte coming from one patient are connected to each other. So you should make the mean fertilization rate per patient and not calculate the total of the oocyte injected and the fertilization rate. Because imagine that you have one patient with 20 eggs that has a very low fertilization rate, and then you have 20 patients with 3 eggs, but single patient that had a low fertilization rate will bring you whole fertilization rate down if you count oocyte per oocyte. I don't know if it's clear, but this is why I'm saying I am master in statistics. I took a master in statistics because I understood how much data need to be collected, but also the interpretation of the data is essential to be sure that you are really on everything under control.
We need to be smart. We need to be smart while calculating KPIs. All right. So now next question is for Lars. This is because, Lars, you did mention earlier in the discussion and something which caught my attention. What is the relationship of pregnancy loss rates with, I mean, how do you, if there's a sudden increase in pregnancy loss rates, how do you troubleshoot that? Because unfortunately, you find out about such a drop only much later, which is, say, 8 weeks or 12 weeks from the event. So is there anything which correlates with pregnancy loss rates in the laboratory?
Well, if you look at, they're so multifactorial, it's really hard to look into what it is. But have they changed anything in the hormone protocols? Have they done any other techniques that have been changed? Type of patients we have, for instance, just before Christmas or just before summer, everyone wants to have an egg collection, despite that you say that it's not optimal. And they still come with, they haven't got the proper stimulation, they haven't got the immature eggs, they still want to have an egg collection. And that will affect your results at a certain time. But the combination, as I mentioned before, of male factor and poor responders is really, really bad. But if you have a big program, it shouldn't just drop suddenly.
Yeah, exactly.
It must be some more environmental things, or it could be drifting in equipment. So it's a lot of things that can go wrong.
So you really think that VOCs can actually having far-reaching consequences on sustaining pregnancy?
Yeah, I've seen that in for instance, we had a helicopter pad where they come with the ambulance helicopters, and it came into the lab, and then it drops the results immediately. And I've seen that in other places also where they have fires around where they have the clinics. Mm-hmm. And the ones that had protected themselves with a good ventilation system, nothing happened. Mm-hmm. And it's a lot of this, but you can't, when you have a drop, I mean, sudden drop, it must be something very, very bad happening in the environment, or a disposable or something you changed from the company that gives you the culture media.
Yeah. Ronnie, you have anything
Well, yeah, I agree with Lars. First of all, check the factors which are external to the laboratory, such as changes in mean maternal age, maybe changes in stimulation protocols, that's obvious, but also the transfer policy, a shift from day 3 to day 5 or vice versa can have an impact, shift in the number of embryos to be transferred. But when all these factors are stable, then you have to look to some kind of toxic effect. Now, in this case, I find VOC a bad example. Of course, it can have an impact, but if you control properly, there are nowadays real-time monitoring systems to measure VOC, so you should be prevented when these spikes of VOCs happen. We know, and then you should close the lab for a while. Should not let it come that severe.
Can I mention? There was a clinic on the coast of Sweden, and there's a huge airport there. The wind changed, and the results went down totally. And they measured the VOCs; it was super high, even outside. So it was not a proper ventilation system. So they got still in, and they just dropped.
Quickly bring in Alex for a short comment, then we'll move. We have only about 15 minutes left. So
It was a question to Ronnie or Lars, because so many people have got a doubt regarding the HU, because some people put an HU specifically for the IVF laboratory, exclusively for the IVF laboratory. Some people put the HU that will connect the OR and other areas of the complex with the IVF laboratory, so that there can be a mixing between that area, especially now after the COVID. Many people are using alcohol and other strong disinfectant in the rooms. So anybody can comment on that. Better to go for isolated HU for the IVF lab, or you can. I even heard some comments that even if you put the live air system, they have to change the filtration unit faster when they have using too much of disinfectant in the OR.
Well, I can comment on that immediately since you mentioned LifeAir. The thing is that there are so many different detergents that are used out there, and the worst ever is 70% alcohol, and it's overused. It's reducing, but it does not take away, eliminate everything. And then there's others on out there, and I tested a lot of them, and I shouldn't mention any company names, but there are some that are cleaning up nicely, but they are sticky. And after that, it's really hard to work there. We can see the hands everywhere. And so they're sitting there. You have to clean it out also. And then there are new ones that are coming, and they are quite promising. So alcohol, the worst ever.
yeah, alcohol, we know. And Ronnie, you wanted to say something.
Well, I wanted to reply in the same way that nowadays alcohol is used to decontaminate, but it's a mistake. It's just a mistake. Should not be done.
Lara, any comment?
No, I agree.
All right, great. So now let's move on to the next thing, which is cryopreservation, which is now a very, very important and robust part of ART clinics today. And so now we will just talk about improving blastocyst survival. Alex, what are your tips? What are your quick fixes? What people, the things that people do wrongly, how do you fix them?
When it comes to blastocyst freezing or vitrification, ideally you should have a KPA competency rate of 90%, or can have a benchmark. You can keep it at maybe 99%. When it goes down, you have to look at the competency of the operator. That is one of the things, because we are seeing maybe those clinics who are adopting the vitrification, they had a variable results in the earlier years. So that need to be corrected. One has to follow the manufacturer's instructions. Other thing that you notice is that sometimes people use the heated stage for warming or during the vitrification process. That need to be avoided. And another thing that has to be kept in mind is based on the publication that we are showing in this slide that came out from China. They looked at the FPT at the fresh transfer rate, blastocystic pregnancy rate. They were showing that in the vicinity there is sulfur dioxide and ozone concentration is high. Their FET rate was lower compared to the fresh blastocyst transfer rate. They attributed that to the damage that is done by this kind of sulfur dioxide and O3. So again, when you expose that blastocyst to the damaging effect of the cryoprocess, I think that is happening a second level of damage. That might be one of the reasons. Another area is that many batch IVF centers in different countries, maybe one person is doing the vitrification. After that, maybe an assistant, a technician carried that whole thing for the storage. That sometimes happens in some batch IVF centers. So you don't know how the way they are keeping and when they take it out. So that another area is that tank failure. You have to monitor the tank. Now there is an advanced system. Even thermal imaging is also now available for the tank optimization, or you should have a proper systems in place. These are the areas I think is very important.
All right. So that's great, and that brings us to our next question for Ronnie as well as Lars can take this. That how do we optimize the usage of storage space when freezing embryos, and we're just piling up tanks after tanks after tanks after tanks with the new freeze-all policies coming in, and then there is so much space wasted in these tanks once you thaw the embryos. So where are the proper systems for inventory management in cryo storage?
Okay, excellent question. I came from a center who now does 5,500 up to 6,000 cycles, and we historically started cryopreservation or cryostorage in the classical DVARs. And at a certain moment, you ran into the limitations of such a system. First of all, the space, you just simply do not have enough space to put all these tanks. That's one thing. They need to be stored in a dedicated area to start with, so you need to have the right facility to have them. But it becomes really very difficult to manage all these manual top-ups to fill them with liquid nitrogen. There's the increased risk of tank failure if you accumulate. We had at a certain moment up to 60 tanks, so that there are risks of failures, risks of or complicated monitoring. So I think many centers will see the end of the classical DVARs. The alternative, in my opinion, an easy alternative is the use of high-capacity storage tanks, which are now equipped with automated systems with automatization for liquid nitrogen supply. They can be alarmed in many different parameters. So the level of security there becomes much higher. But I think even that has, even such a system has its limitations. For instance, you need to have a disaster plan in case of, like now we are faced with the COVID, in case there is no staff available, or even labs have to close down for whatever reason. You need to have a plan B to move these valuable materials to somewhere else. So you need to have a disaster plan, and you need to know how you're going to move, who will do it. So that's another level of security you have to think of. And I think finally, and these are now systems which are now developed commercially, I think we should consider if it's not in the long term wise to outsource cryostorage. There are now services available where you can vitrify and RFID track the complete process from vitrification up to storage. And these vitrified devices with RFID can be transported outside and be stored there with online monitoring and everything. So I think in the long run, we have to go for, or we can go for outsourcing, but in the first issue is going for high capacity automated storage tanks.
I have to agree with Ronnie in many of the things he said. We are using isothermal tanks, and they are vapor tanks. And they're quite easy to use. And it's one of the few that actually put the liquid nitrogen coming from up, so you don't have a gradient inside. There are many big tanks that have gradients in them, and that's a big problem. The other big problem with these big cryo storage tanks is that people are leaning over and they release a lot of cells and so on from the body. And you get a lot of that coming down in the tanks. And there could be a contamination, but maybe you should talk to Parmigiani, Ludovico, more about that. But I agree, it's better to have big tanks, to filler tanks, and maybe have a backup tanks, unfortunately. And the fillers are standing outside, so you don't have to roll them in because they're quite dirty. The other thing that's happening also here in Sweden is that you have these companies that stores everything that Ronnie was talking about, and they take care of everything. And they have also this kind of filler tanks, big ones. So there's those that can't afford it. They can take, there's some new tanks with double canister that you can store more per canister. Then, of course, how many embryos or eggs do you put on a carrier? And how big is the carrier? Because there are small carriers and there are big carriers, so they take more space. But at the same time, if you put too many embryos or oocytes on a carrier, I feel that people are putting them too high, and then when they want to warm them, it doesn't go under the meniscus of the warming solution, and then they are dead. So it's risky to do that. But again, there are so many systems on the way, and I think there are more coming out where you can control with not only this that you have from Research Instrument or Matcher. It's more coming out, and we'll see in the near future.
So I'm sure now, we will have to resort to these changes in our daily practice, where perhaps, it's the whole idea of outsourcing cryo storage or relocation of that cryo storage, that doesn't occur to us, but might be a very, very useful solution for the whole problem. So now this is a issue this is the last issue that we're going to address in this discussion, and which is about IVF mix-up. And definitely all of us maintain that my lab never makes a mistake when it comes to putting the right sperm and the right egg together. Well, there are people who may admit that mistakes are very rare, or the last mistake was in 1989, and some people clearly don't know. So now the next question is for Laura, and then I'd like Alex also to give his comments. So now there's a patient which visits your clinic, and her primary criteria of all things to choose your clinic is that she is morbidly afraid as to how you will ensure that her sperm and embryos will not get mixed up with someone else's. So how will you convince this couple to go ahead and undertake their IVF in your center?
Okay, I think that couple needs to be reassured always, and it's not apart from the system that you use in your lab, and I'm using an automated system for traceability, but this is not really the point. When a patient is morbidly afraid about anything, we should support her, and we should support her with a psychologist, because this is just a symptom of something which is much more deeper and profound in the couple. So I don't think that we have to convince patient to do anything or to come to your center. As a philosophy, we should convince patient to be reassured, to decide the treatment with really with understanding what they are doing. So apart from that, so the idea to have an electronic witnessing system is not to have more patients or to reassure patients, because you may have also a manual system which is very trustable. It's more for the laboratory. So it is for the quality control. This was Ronnie says, you invest in quality control and you get much more than what you have invested. So it's difficult to convince your boss to invest in an electronic system, because it's not going to bring patients, it's not going to bring more results in terms of clinical outcome. If you say to a gynecologist, please buy this incubator, it doubles the pregnancy rate, you will have it the day after. But if you say, oh, it's just controlling the lab, I think it's more difficult. But in my center, I was very lucky. Everybody agreed that to increase the quality control and was very important. So we put the electronic system in 2012. So it's now 8 years that we're using this system in all our centers. And it's really incredible the advantages that we got. Not only
center is a very high volume center, and I have seen there are tons of people working in shifts after shifts, and it's completely insane. So definitely, it must have really helped. Channelize.
It helps. Yeah, it has big center, but it helps also small centers. This is a mistake to imagine that only big centers need it, because big centers are trained to shift, have always a witness available, because big centers mean a lot of staff, and means that you are never alone in the lab, means that you have a highly trained colleagues, while in small centers you may have one embryologist trained, one in training, and one technician, and you may be alone on Sunday, you may be alone on a holiday. So absolutely is not related to the amount of cycles that you do, probably it's related to the number of staff per cycles. But it's not only this, the advantage is not only the traceability for mix-up, because this is a rare condition, we are all trained for that, but it's also to have a control of timing of procedures, number of procedures performed by staff. I can know how many ICSI were performed by any member of the staff. If one is doing too much something and the other not enough, we can really have a control of the whole laboratory procedures.
It's a very useful tool for quality control. Alex, do you want to add something to that?
Yes. When we talk about, because the question was if a morbidly afraid patient, it is not only that. I think there was some study done that was published in a journal 5 years back. That was survey-based study that shows that 90% of the couples coming that undertook that survey, 90% of patients are afraid of the mix-up, and that says that maybe that electronic witnessing helping around 95% of that group. But again, when you have such patient, particular type of patient, it is more of psychological, as Laura has mentioned. Maybe you have to coordinate such patient with your counseling team and your embryology team, and maybe initially you should have a walkthrough through your facility. If not possible, maybe you can show the videos how your system is working, how your total quality management assures that you have checkpoints at each level, starting from the sample collection to the embryo transfer, with color coding of its human witnessing, how it is being controlled. That need to be assured to the patient. And also, such patient may be skeptical about the whole process. So maybe you need to call the patient from starting from fertilization until the embryo being frozen. You have to call them and tell the dates. So this way, I think you can manage to some extent.
All right. So communication and counseling is very, very important in this regard. George, do you want to say anything?
Just to add, I mean, everything is very correct. Just to add that also when there is an electronic witnessing, there is no distractions for the people performing their individual tasks. So when you're using a double witnessing system, then it could be that any time someone is focused on their either vitrification or ICSI, and then someone steps out of the lab. And in a busy lab, the turnaround and the witnessing can be sometimes that you have to think what everyone else is doing in terms of the timing. So it can offer you time to fulfill a certain task without distraction and less mistakes, and it can work in a better flow in the workflow.
All right. Yeah, Ronnie, please go ahead.
Yeah, just one comment. I don't agree with Alex saying that it's a tool for quality control. Doing quality control in IVF is too late. What we should do is do quality assurance. We need to prevent errors of happening, and that's why you need these tools. And again, it's part of good manufacturing practice. But we should not forget that zero risk does not exist. Even the best burglar systems, sometimes some jewelry stores are robbed. So zero risk does not exist. There are residual risks. But at least now we can prove to our patients what we are doing, and we increase the level of transparency, and I think that is important as well.
Yes. Well, that was a good closing comment. So I think we have come to the end of our agenda to be discussed. We have finished in the nick of time. It's already 90 minutes. So is everybody exhausted, or do you want more?
We can take some questions.
So we can definitely take some questions, and let me just quickly see where the questions are. So there were tons of questions streaming in as we were discussing these various topics. However, they were just raining in. So I will probably like to get a look at them. Bharat, if you can. Okay, all right, yes. So there are a lot of questions actually which are addressing issues related with the COVID times. So there are lots and lots of them. And I will just quickly see where's the chat gone. Yeah. So yes, there's a lot about COVID times. There's additional delay in culture media availability, and these are all short expiry items. So how to fix, how to address this problem? Yeah, George.
I mean, we have experienced a lot of delays, especially with the courier services and postal services. So it's important that your media provider can guarantee that there is a temperature logger packed within the media, that you can assure that there was no temperature variation during shipment. So this is very important to have control over, even if there is a delay, to make sure that there is no variation in the temperature during that period.
Okay. And there's one question where a Dr. Sarab Singh has asked that what is the reason for good fertilization rates but poor embryo quality on day 2 and 3? So I think we did answer that in our discussions, where we're looking at good fertilization but poor embryo quality. So we go through the stepwise protocol that was explained by George, and try to find the problem size. Then there's a question about the drop size. Does that affect fertilization rate and embryo quality? Would anyone like to take that? Yeah.
Okay.
Lark.
No, when I started in IVF a very long time ago, we used tubes, and it was a big volume, and we had very good embryo development. Because someone told me the toxins float up. If I can believe that, I don't know. And then we had small drops, so micro-insemination, and you hit harder the eggs quicker. And then we lifted it to clean for a very short incubation time. But when you do, like Swan et al., they have written a lot about, the smaller the drop you have, the more important is it to make it quick because of evaporation, osmolality, and so on. And if you have, again, I'm coming back to malfunctioning class 2 loft benches that are over-cluttered, you put in a lot of dirt there, and you don't protect them in a good way. And then if you do more than one dish also, it's even worse. Mm-hmm. So we now regularly we did have sentable dishes for the insemination, and it's 600 microns, and we only use some 50 to 100,000 motile sperm. So if you can get down the sperm also, then you also have a better culture later on. And there was a mistake in the lab. I can't hear you.
Right? Dish
I can't hear you.
dish preparation is very vital. There is a question for Laura, specifically for Laura. What is your recommendation on the time interval between thaw and transfer of frozen blastocysts from your studies in your center?
Yeah, we did a lot of studies on vitrification and warming, especially on blastocysts with biopsy or without biopsy. And the re-expansion rate of the blastocyst was really very important in predicting the implantation. So if a blastocyst starts re-expanding within 2 hours after warming, the implantation rate was really very, very, very low. So we keep the blastocyst between 1 or 2 hours to assess the re-expansion.
Okay, 1 or 2 hours. So, all right. And then there's a question which says, by Dr. Rajesh Gorasia, do you think too much HMG may lead to difficult aspiration of, may lead to difficulties during ICSI as far as aspirating the cytoplasm is concerned? So does too much HMG affect egg quality during ICSI? Any comments from any of the panelists? Right. George or Ronnie?
Well, we do know that hormonal stimulation has an impact on the oocyte quality, that's for sure. There is literature about that, but I'm not aware of any doses on HMG on oocyte quality, that I don't know. But the stimulation is sure.
Okay. All right. Let me just ask one more question and then we can close the discussion. Yeah, okay. This is one question. What is the effect of a dry benchtop incubator versus a humidified benchtop incubator on embryo culture? Are there any specific? Yes, Ronnie.
Yeah, that's a hot topic, dry or humidified culture. The issue is that osmolarity is one of these many parameters, as is temperature one and pH is one. So you have to manage osmolarity in a dry incubator if you're using a dry incubator. Drop volume, for instance, is a factor which is important. The layer of oil is important, so the thickness of oil, but I mean it is a variable to control as the other variables. I don't think there are really excellent randomized trials compare dry and humid incubation. There are some, but there are some methodological issues there. In my opinion, and I've been a promoter of benchtop incubator, dry culture. This kind of technology, so dry culture, allows the development of more complex incubator systems. Where it is with humidification, it's not possible or extremely difficult to do. So, well, that's more or less my answer.
All right.
May I add something?
Yes, sure, Laura.
Just to conclude, at the time of COVID, which is aerosol-mediated virus, I think that, of course, dry system may be more reassuring, although I don't believe really that cells are bringing the virus, but ourselves as embryologists, we can potentially transmit virus to our incubator, and a dry system will be more reassuring, I think.
Okay, so I have a quick question. The benchtop incubators that we use, which share a common humidification flask between both the chambers. So what is your take on that?
Okay, today sorry.
No, please go on.
Laura, go ahead.
But related to the COVID situation or related to the culture system in
Because
general?
the final question is, would COVID possibly influence IVF results
Exactly.
to any extent? So we'll close.
Okay, the point was that. So, of course, today is not an issue because we are wearing the right PPI, so we are protected and we are not risking to introduce the virus during the opening of the incubator or changing the flask. So, I don't think that is an issue really in the lab when we wear right PPI. And the biologists know how to behave and not to infect anything. What we were scared, it was February and March before the pandemic was really declared and we were working normally. And in Italy, there was already a lot of infected people and we didn't know in January and February. So, of course, this is why I think that if you use single chambers, no connection between the chamber, you may prevent things that can happen after. And as Ronnie says, it's much more important to have a quality assurance system than a quality control, but everything has happened and you can just assess the problem.
Okay, so but Laura, most of us have incubators, the desktop incubators, which don't have single chambers, which have chambers where multiple dishes are put, and they too are connected through tubes, bringing in the moisture. So now,
today we know that we potentially contaminate, so we will never not wear gloves. So today, after the pandemic has been declared, you wear gloves, you wear masks, you wear goggles, you dress, long sleeve. So there is no reason to be scared in the lab because we know how to wear PPI. We know how to.
What about the virus?
Cell to cell.
Cell to cell, yes. Patient to
cell to cell. No, cell to cell, it's impossible.
Okay.
First of all, even if they would be, we don't believe because it's an aerosol-mediated virus. So I'm scared about the aerosol and I'm scared about the blood. But even if they would be, all the washing that we do at egg retrieval, all the sperm wash that we do, finally when we have the oocyte and the embryo, the quantity of virus, which is not going to jump from one dish to the other, will be so low, and the oil and everything that we have, we know how to manage potentially infected samples. So we should trust ourselves, and with our culture system, we should not be scared about cross-contamination between cells. I would be very reassuring about that.
We should not be. It's very reassuring. We should not be worried about cross-contamination. We'll close with Lars and perhaps a call from Ronnie. Yeah, Lars.
Yeah. No, I'm thinking about, again, the ventilation system, what you're using, because it can also eliminate those contaminations. And it has been tested for it also.
So Lars is the ventilation man here. And
I think Ronnie is.
Well, to go on ventilation, HEPA filters do not block aerosols, so we should know that it does not protect you. But about aerosols, there is one thing where I think we should be concerned, and it's during centrifugation of sperm. It is possible that there are some aerosols generated during centrifugation, so be careful there. Be sure that the tubes are closed in case of leakage or something, that the centrifuge is properly decontaminated, and do it one by one.
Okay, great. That's very valuable information. So Alex, George, now we can perhaps close this discussion.
Yeah.
We've been at it for quite some time, and I would like to thank every single panelist here who gave their precious time to be with us here and discuss so many things in detail. Alex, I'd like you to close the discussion, please.
Yeah, thank you everyone on spending this much time, and it was very productive. And we had many, I heard that 500 participants were there from around the world. And it was a really nice discussion from each expert. And I would like to thank everyone for contributing to this course. Thank you very much.
Bye-bye.
Thank you very much.
Thank you.